All right, guys. Now we're gonna start this part of the presentation. My name is Nisha, and it is my honor to host Dr. Sabre with us today. So a little bit about him. He's originally from the East Coast. His training in medical school brought him to Phoenix, where he discovered his passion for women's health. He completed his residency in obstetrics and gynecology at the Lincoln Hospital in Bronx, New York. His training encompassed extensive management of both routine and high-risk pregnancies, and full spectrum gynecology, including minimally invasive surgery. Obtaining multiple publications in the field, he remains committed to continuing research in medicine and opportunities that can improve the wellness of people on a local and global scale. Outside of medicine, Dr. Sabre enjoys the outdoors and traveling with his husband, Jesse, spending time with their two energetic French bulldogs. Please welcome Dr. Sabre.
Great. Thank you so much for having me. And I'm so happy to talk to you guys about a topic that is very common in obstetrics and gynecology, and something that we encounter, as a generalist OBGYN, basically, daily, when especially you're on labor and delivery. So, this is a procedure that, some of you may even have been born via C-section. So without further ado, we'll get started on our topic and everything. And just pull that up and share with everyone. And then I know we're going to go over some of those polls. Nisha, if you want to, shall we go over those polls first, those first initial ones?
Yep, I'll go ahead and launch the first one.
Great. And let me just stop sharing for a moment while we pull this up. So good, some polls. So really the first one is, I know this is broad to everyone, and I'm sure you're interested in learning about all the different fields of medicine, but really this poll is, what branch of medicine really appeals to you? We have internal medicine, pediatrics, general surgery, we have psychiatry, family medicine, OBGYN as well, and many other different surgical subspecialties, which, there's so many different branches of medicine, ortho, plastics, urology, as you talked with right before me was, cardiothoracic anesthesia. So, within those different fields of medicine, there's even more different subspecialties. With OBGYN specifically, we have maternal fetal medicine, which is really kind of a mix between internal medicine and OB, where, managing these high-risk pregnancies. Gyn-oncology, so cancer with any kind of gynecologic organs, because of, that can be things that can help decrease morbidity and mortality with those patients, of ovarian cancer, cervical cancer, uterine cancer, very common things, vulvar cancer, vaginal cancer as well. Urogynecology, so kind of that's specific because of the way the anatomy of OBGYN and gynecologic organs are close to the bladder, so kind of a mix of that and repairing different things. Minimally invasive gynecologic surgery, so a lot of robotic surgery nowadays, laparoscopic, these single site port incisions, even, surgery that's through the vaginal vault, decreasing the risks of abdominal scarring. So, OBGYN is so broad and so much, interesting things. So good. I think we have most people kind of took the poll. So I'm going to end it right now. And it looks like we have a lot of people who are interested in, these surgical subspecialties. OBGYN really is a mix of that as well. So I think we're good with that. We'll share those results and everything. So good. And then if, shall we go on to our next poll? Great.
We have the second question. The two questions were asked together.
Oh, did I delete the poll? I'm so sorry. I think I might have.
No, you're good. You're good. I think everyone can still see it, but the second question was asked with the first question.
Oh, okay. And let's see. I'm trying to pull up the poll quizzes. Okay, there we go. And the two question. All right, then let me see. Oh, there we go. And then so some aspects of the career in medicine that are important to you. So, we have a good mix of people that really want to build important, long-lasting relationship with their patients, understanding dynamic physiology in relationship to a lot of pathologic disorders, being able to work with your hands and having, things that are procedure-based, encountering a problem and feasibly reaching a solution, managing, many diverse yet focused problems. So this is great. This is a great poll because I think it really applies to OBGYN, just because you're able to, with our field of medicine, building these long-lasting relationship with patients as a provider of women's care, understanding focused, physiologic disorders and, understanding them because of, especially in pregnancy, the dynamics of that physiology, has really changed a lot because of, adding the fetus, fluid dynamics and everything. We'll talk about a procedure that we encounter today with obstetrics, and there's many other procedures in gynecology. The beauty of obstetrics is as well, we have a problem, pregnancy, and that feasibly has a solution, delivery. So which is a great thing, with this field of medicine, as opposed to other fields of kind of managing chronic disorders. This one you're able to, have that problem and focus on it, and as well, managing diverse problems, abnormal uterine bleeding, pregnancy, fibroids. All these things are, diverse problems, but they're really focused on the gynecologic and women's healthcare. So that's some of the beauties of OBGYN. So great. Let me share my screen and we'll start off with our topic. So good. Let me just pull it up real quick. Play it. Come on. Excellent. All right, great. So yeah, this is our steps of evidence-based cesarean section. I am a OBGYN through Honor Health System, which is here in Phoenix, Arizona. And I'm on the Department of OBGYN at my hospital. So I don't have any disclosures to announce with giving this topic. Some of our learning objectives that we're going to go over today is we're going to review the epidemiological and backgrounds of cesarean section. Excuse me. We're going to develop an understanding of the surgical process and the evidence-based preoperative and intraoperative, and then finally the postoperative steps as were set apart by the Enhanced Recovery After Surgery, or ERAS committee. And these are all different steps that are evidence-based in order to improve outcomes for these patients undergoing cesarean section. So I think, Nisha, let me stop right here sharing, and this is going to be our third poll right now. Good. So our poll is going to be, what do you believe is the origin of the term cesarean section? So, unlike the Caesar salad, which is named after Augustus Caesar, who was born via this method. So you have it derived from the Latin verb cadar, meaning to cut, and the delivered infant known as caesones. We have this Roman decree of all pregnant women who died in childbirth needed a post-mortem to be cut open. And if that child died, would then be buried separately. Lastly, we have in 1598, this publication on midwifery, which utilized the term section as opposed to the previously derived cesarean operation. So we'll let 10 more seconds go over just while people are finally picking their question or answer, excuse me. Great. I'm going to end this poll. So actually, it's a little bit derived from all of these. So, they believe that, that Roman origin of that Latin verb cadar, was really kind of the beginning origin, but also it was set with Roman laws and everything that, all women, pregnant women who, started to pass, would need to be cut open in order to save the baby. If that baby died, unfortunately, in childbirth, then they were to be buried separately. And then there is this publication where they, which is interesting, on midwifery, which is really origins of the field of obstetrics, that use this term section as opposed to cesarean operation. So, and then there is this long-held belief that Augustus Caesar may have been born by this method. So, but there is kind of, some background that, his mother was known to have been alive when he was emperor. So, probably, some fiction rather than fact in regards with that, but, kind of a little bit derived from everything. So we'll go back to our case and everything. Let me just make that smaller. This up. So yeah, we talked a little bit about the background of C-section. So we know that in the United States, cesarean section rose from 4.5% in 1970 to 32.9% in 2009. This was really, the biggest factor that increased this was the use of fetal heart monitoring. And sorry, I'm just getting this poll. Let me just close that poll out. It's right in front of my stuff. So. And then from that peak in 2009, it has downtrended because we know that the preferred delivery method is vaginal birth, and we don't want increased C-section because of the risk of, this is a surgical procedure, which, can affect mom, and long-term, with scar tissue, with the effects on the uterus and everything. And really, there's been a push to, decrease the amount of C-section in the United States. And this is downtrended from 32% in 2015 to about, a little less than 32%, 31.8 in 2020. And that's all from the CDC. This is the most commonly performed surgery worldwide. So they say that about every minute, about 5 C-sections are performed worldwide. So very, very common. And the indications for C-section, about 85% of them are for prior cesarean section, labor dystocias, so failing to progress or dilate, fetal jeopardy, so that non-reassuring fetal status, we're monitoring these babies. And, we're seeing that their abnormal fetal heart pattern, is telling us to intervene. Lastly, the indication is for abnormal presentation. So the most common thing being breech. So instead of the head being down, but, the feet or buttocks. So some background on maternal morbidity and mortality. So, that even though this is a very commonly performed procedure and surgery, that there is risks of mortality, about 2.2 per 100,000, deaths in C-section compared to 0.2% per 100,000 in vaginal birth. So, pretty significant increase as opposed to vaginal birth. We know that about 13 in 100,000 with an elective repeat C-section, which is much more than 4 per 100,000 women who are undergoing a trial of labor who've had a prior cesarean section. So, vaginal birth is preferred, but, if in cases where we cannot perform that, then C-section and, explaining to patients that risk. Some more maternal morbidity rates are also increased twofold as opposed to vaginal birth. And the biggest things in regards to this are infection, hemorrhage risk, and thromboembolism, things such as deep vein thrombosis, DVTs, pulmonary embolisms, or PEs. Fortunately, in our day and age, anesthesia complications are rare, but are still one of these morbidity things that can happen with cesarean section. So one thing that should be noted is that there's actually a decreased rate of urinary incontinence and pelvic organ prolapse in patients who've undergone cesarean section as compared to vaginal births. But, these decreased rates are really not significant to recommend, this as a route of delivery in patients who want to, avoid these issues. And that over long-term affects, those basically those distinct populations of patients who've undergone cesarean sections versus vaginal births are actually, basically equal, in their third and later stage of life. So let's talk about some of the preoperative pathways of what we're going to be doing, when we're preparing someone for cesarean section. So it's recommended to have informed consent of the with the patient about the procedure and everything related to the surgery. So risks of bleeding, infection, damage surrounding tissues and organs should all be known to the patient. In regards with their pre-anesthetic medications, it's really big to administer a lot of antacids and histamine H2 receptor antagonists, things such as Bicitra, which helps to neutralize the stomach acid, Reglan, Pepsid, these are all antihistamine receptor blockers that help your body to stop secreting that acid, in order to kind of slow down the gastric pathway, in order to prevent nausea, vomiting, especially during the procedure. It's recommended to not administer any preoperative sedation to the patient. So, keeping them alert and oriented while you're preparing them, is recommended just for, patient comfort and everything, and helps to prevent a lot of these, problems that we'll go over, especially with, fasting and everything. So the preoperative bowel preparation. So as opposed to other surgical processes, in general surgery where you may consider bowel prep to kind of, remove stool and everything from the colon, it's not recommended to either administer oral or mechanical bowel prep to the patient prior to surgery. And because of the increased motility to the gastric system, this can inflate the bowels and, put them into the operative field, which is one thing that we don't want to do. We're operating strictly on the uterus and on no other organ system. So the last thing to talk about is preoperative fasting. So, the old adage and where a lot of surgical procedures really started on was in obstetrics with, patients, fasting prior to their surgery. And this is really important with the fasting aspects because, with the beginnings of obstetrics, when cesarean section was first started, stopping what's called Mendelssohn's syndrome or aspiration pneumonitis. So pregnant patient vomiting and then aspirating it into their lungs, causing, that chemical pneumonitis and, all that different sequela. So, we used to tell all patients to fast, but it's actually been recommended because of our, these pre-anesthetic medications, the antacids, the H2 blockers, that actually patients, won't vomit and aspirate their gastric contents. And actually by making sure that their, stomach is full and actually, carbohydrate supplementing them can actually improve other than patient satisfaction, but their recovery. So in a lot of, these ARIS pathways, encouraging patients these clear fluids up to 2 hours before surgery, light meals up to 6 hours before surgery. We don't want them eating, Whataburger or McDonald's or anything like that, but, small meals up to 6 hours before can actually be recommended. And this preoperative carbohydrate supplementation, which is a part of our ERAS protocol in my hospital, is offering all of these non-diabetic patients this oral carbohydrate fluid supplementation up to 2 hours before surgery. So next, we're going to talk about the intra-operative pathway. So things that we can do to help decrease morbidity and mortality to our patients. So this preoperative antimicrobial prophylaxis and skin preparation. So administering all those IV antibiotics within 60 minutes before that skin incision is made, using a first-generation cephalosporin, most commonly Ancef, with patients who have a higher BMI of greater than 30 or an absolute body weight of more than 100 kilograms. Using higher doses of those antibiotics, typically 3 grams of Ancef as opposed to 2 grams. It's been noted with the CSOAP trial that patients who presented either in labor or with complaints of ruptured membrane, their water broke, by adding azithromycin 500 milligrams once helps to decrease that risk of surgical site infections after a patient has undergone cesarean section. So that's routinely recommended. The skin preparation, using what's called chlorhexidine alcohol, which is kind of this orange solution that comes in almost like a little squeegee to cleanse the abdomen, is preferred as opposed to aqueous povidone iodine, which is an iodine-based solution that kills the bacteria. Chlorhexidine, though, is an alcohol-based preparation. It requires at least 3 minutes for the solution to dry, or else this can be a fire hazard in the surgery. So for patients who are having to undergo emergent cesarean section, then using povidone iodine, because it can basically cleanse the abdomen, within those seconds of after its preparation. There's this talk about using a vaginal prep to help to decrease that, the flora of the vaginal bacteria, which can then, be placed inside the cesarean scar and cause surgical site infection. So there's a consideration to using that povidone iodine kind of scrub, although this is weak evidence, maybe something to consider. With anesthesia, the management of that specific anesthetic regimen should use regional anesthesia. So things like epidural and spinal should be preferred modalities as opposed to general or putting the patient to sleep specifically for their cesarean section. And lastly, by preventing hypothermia. So by keeping the patient at a normal or close to normal body temperature has helped to shown to decrease the risk of surgical site infections, ease recovery and everything. So using appropriate patient monitoring to apply the warming devices, using either forced warming air or warmed IV fluids, and also increasing the OR temperature helps to decrease infection risk, not only to mom, but also to the newborn infant at that time. Next, we're going to review some of the anatomy. So looking at this cross-section, sagittal section of, the female anatomy, we see that the uterus and the fallopian tubes and ovary really are kind of this pelvic organ that's, in between the, GI system, rectum, large intestine, small intestine, and the genital urinary system, the bladder, urethra, and everything. So the uterus, which is a pelvic organ prior to pregnancy, rapidly increases and in size and becomes an abdominal organ, above the pelvic brim in the second trimester and throughout the rest of the pregnancy. So really, there's a lot of different specific organ systems that are close by that the OBGYN really needs to be aware, when performing this surgery. So let's talk about some of the anatomic layers that we're going to encounter when doing our cesarean section. So, most commonly we do our incision on the lower abdomen, and we'll go over that specific incision type soon enough, but we go through our skin layer, the dermis and epidermis. Then we get to our subcutaneous layer of the different fatty layer tissue. Once going through that layer, we get what's called the fascia layer, which is this fibrous, connective tissue layer composed of both the camper and scarpa. This is really important because this basically, think of it as like an internal corset that holds all of the internal organs inside to prevent hernias and everything. So next you have your abdominal muscle layer, and then 5 is your peritoneum, which is right below the abdominal muscle. This is the layer that holds all of your internal organs, the intestine, uterus, bladder as well. And then finally, we get to our uterine layer. So you see this nice picture of, kind of going through the skin incision, then the fascia, separating those muscles and everything. Then once you get to the uterus, making that a uterine incision and delivering the fetal head. So let's talk a little bit about our skin incisions that we're going to be doing. So, the preferred is doing a lower incision on the abdomen that's transverse, so horizontally. This is most commonly placed 2 centimeters above the pubic bone. So the obstetrician gynecologist, once the patient has been prepped, is able to palpate where the pubic bone is and making that incision above. Most common types are called either the Phalansteal, which is kind of a curvilinear, that 2 centimeter above. Joel Cohen, which as well is that 2 to 3 centimeters above the pubic symphysis, which is instead of curvilinear, just linear horizontally across the abdomen, most commonly about that 9 to 10 centimeters in size. Other types of incision that we may do is what's called a Maillard incision, which is more curvilinear, more cephalad to the umbilicus, so closer to, to the belly button, closer to the patient's head, where you're able to isolate the vessels, because all of the abdominal major vessels, that supply the abdominal wall come to the sides laterally. So with the Maillard incision, you're able to really isolate those what are called the inferior epigastric vessels, which come through the arterial system, and isolate them prior to making your incision further down, and this helps to decrease blood loss and everything. So the last type of incision is called a Czerny incision, which is similar to a Maillard, but instead of isolating your epigastric vessels, you basically remove the abdominal rectus muscle from its connection to the pubic bone. This is not really seen in obstetrics, but more so with gynecology, especially in gyn-oncology, where you're really, trying to, isolate and show as much of the tissue as possible. So finally, the last type of incision that you may consider to do is called midline vertical incision. So that's just a vertical incision that's midline below the umbilicus, and this has the benefit of decreased blood, hemorrhage because of those blood vessels that are more lateral to the incision. But one of the negatives is that this is a scar that will be above the bikini line, as opposed to Pfannenstiel, Joel Cohen, even Maillard, and it also has that decreased risk because of the way the connective tissue is of wound dehiscence, so breaking apart and everything. So once we've kind of gone through our layers, we're going to talk a little bit about our uterine exposure. So you see our picture on the left, that silver instrument is called a Balford or bladder blade. This is placed, above the bladder. That pink tissue right in the middle is the uterus, and this helps to isolate the bladder so that we're only, visualizing the uterine, tissue and everything. That person is using their hands. You can use another type of instrument called a right angle or Richardson retractor, which basically helps to, isolate that tissue. And a lot of times nowadays, we use what's called the Lexus retractor, which is on the right-hand side. It is these two kind of O-rings connected with plastic that is placed in that peritoneal cavity, and really helps to isolate the uterus and keep the different, organs out of the way. So your bladder, bowel and everything. What the pink O-ring, once it's been placed, then you basically just twist it down. So curve it in on itself so that it's flush with the skin, and you're able to have that kind of excellent exposure. All right. On our next step, so once we've kind of isolated our uterus, I'm going to talk a little bit about what's called a bladder flap. So really, when we're here to, deliver the baby, we want to, make our incision on the uterus, deliver the baby, and not do anything else. We don't want to affect any of the other internal organs, especially the bladder. So a bladder flap is basically cutting this visceral peritoneum, that's connection between the bladder and the lower uterine segment, in order to isolate the bladder from that, lower uterine segment. It helps to create more access to the lower uterine segment, in addition to reducing that risk of damage to the bladder during the C-section. So a lot of the times we make this incision on the bladder, the uterine serosa, and then kind of bluntly, as it's demonstrated in that first figure, using our fingers to kind of push that bladder away, then adjusting, with either the Balford blade or the Lexus, retractor to help keep that bladder out of the operative field. So our uterine incision, the reason why, we're doing that bladder flap is because the preferred modality is making a lower transverse incision on the uterus. This low transverse incision allows the head to be delivered through what's called a hysterotomy, which is the incision on the uterus. Delivering, once the head has been delivered, then the rest of the body soon will be, as well as the placenta. And this is preferred because a patient who has undergone at least up to 2 lower transverse incisions on their uterus may actually be candidates for what's called a trial of labor after C-section, or TOLAC. Patients, may have to, based off of the fetal presentation, which may be known prior to, the incision on the uterus, and the C-section, maybe have to undergo a low vertical incision, which is similar, to low transverse, where they may, fortunately, if it doesn't go high on the uterus, be able to, undergo those trial of labor after C-section. And then lastly, that classical incision, which, may be preferred in patients who, the fetal presentation is transverse, which may be very difficult to deliver the baby through, or even very preterm patients. With the classical incision, this incorporates the main muscle layer, the myometrium of the uterus. And these patients are unable to undergo trial of labor after C-section because of that risk of what's called uterine rupture. Basically, the uterus starts to contract, that muscle layer where that scar is can break apart, and the baby can be compromised. Mom can bleed out and everything. So, but that is a different topic and everything, but mainly speaking with just routine C-section, we do a low transverse incision on the uterus. So once that lower, transverse hysterotomy is created, then, with fetal delivery, the surgeon is going to place their hands below the head and kind of help to guide it through that incision on the lower uterine segment, using their other contralateral hand, to apply pressure on the top of the uterus called the fundus in order to deliver the baby. In some instances, that difficult fetal delivery, may not be able to be done. This may be, someone who may be laboring for a long time, and the baby is, deep in the birth canal and severely impacted. And you may need to use a assistant to help kind of lift the baby's head up while the surgeon is able to kind of guide that hand through and head through the hysterotomy, which is seen in that first picture. Other things that have been utilized nowadays is what's called a fetal pillow, which is that second picture in the top at 12 o'clock position on our PowerPoint, which is basically helps to elevate the fetal head out of that severely impacted presentation. Sometimes what happens is that despite trying to use these attempts, we're unable to deliver the fetal head. It might be so deeply impacted that, we can't really, get that presentation, and we might need to do what's called a pedalic delivery, or basically a reverse breech extraction. So grabbing the feet and then having that deliver first as opposed to the head through the hysterotomy. And then in sometimes where the head is kind of floating, not really in presentation, we may need to use a device, or the fetal head is so large that we're unable to kind of guide it through with our hand. We may need to use what's called a vacuum. The most common is what's called a Kiwi OmniVac, to basically apply suction on the baby's head to help guide it through if we're unable to, with our hands as well. Once the fetus and infant has been delivered, the next step is what's called delayed umbilical cord clamping. So the surgeon will clamp and cut the umbilical cord, and ACOG, which is the American Academy of Obstetrics and Gynecology, recommends at least 30 seconds of this delayed umbilical cord clamping on routine cesarean births, and at least 60 seconds for vaginal birth, and that's in the appropriate clinical context. So if this is a routine scheduled cesarean section, we do this delayed umbilical cord clamping to help increase the amount of blood that's being delivered from the placenta to the fetus. This helps to decrease, increase risks of blood transfusion to the fetus, helps to decrease, especially in preterm infants, a lot of different medical conditions that are related with prematurity, such as necrotizing and colitis. And it's the preferred modality. So as you see in the picture, once the cord has been clamped in those 2 points, then we make our point of incision. So once the baby's delivered, then the placenta, is delivered as well. A lot of the times, this can be just waiting for the placenta to detach. That's the preferred modality because it helps to decrease bleeding. Sometimes because of other instances of bleeding, we may need to manually extract the uterus, which is basically, going through the hysterotomy, shearing off the placenta from the endometrial sidewall of the uterus and removing it. Once everything has been removed from the uterus, then we start our uterine closure. And this is recommended in 2 layers. The first layer, and looking at kind of our topic, in the pictures here, we have the myometrium, which is the outer layer. That decidual layer is the endometrial layer. So using that first layer of suture, either in a running locked or just a simple running. So basically that it's hemostatic when you lock it, so that it goes through your suture, and this helps to create a hemostatic environment, so to decrease your bleeding risks and everything. And it's used especially, if there's a lot of arterial bleeding, so you see a lot of pumping blood vessels, as opposed to venous, which are more of a simple kind of oozing blood. And then the second layer is this overlaying layer through the myometrium to really hide that first layer beneath it when it's closed. Typically, you do it in a simple running suture fashion, and this helps to kind of strengthen that uterine muscle and everything as well with doing that second layer. So The ERAS intraoperative pathway. So let's talk a little bit about them. So the Joel-Cohen is preferred modality as opposed to fan and steel incisions. And it's preferred because it has a decreased time of delivery of the fetus, a decreased operating room time. There's also been noted decreased blood loss and decreased postoperative pain medication requirements in doing a Joel-Cohen versus a fan and steel kind of incision. We talked about the bladder flap, and even though its routine use has not demonstrated any benefit, it can increase its operative time. This is kind of depending on the clinical scenario, where especially in a patient who's undergone cesarean section before, sometimes that bladder is very tacked up high on the uterus, and by creating a bladder flap to help move the bladder out of the operative field, especially when you're repairing your hysterotomy, that uterine incision. The intraoperative pathway talks about using blunt expansion of the transverse uterine hysterotomy. So kind of making a sharp incision on the uterus first, and then using blunt. So your fingers basically to open up that uterine hysterotomy, may help to reduce that blood loss, because a lot of this time by using instruments such as scissors to cut through the myometrium creates artificial planes of where the tissue would break and tear apart, as opposed to, using bluntly to follow up where the tissue would break naturally. So it's recommended, as we talked a little bit about, waiting for that spontaneous delivery of the placenta. Manual removal has been shown to decrease your postoperative H&H hemoglobin hematocrit. So, in postpartum hemorrhage. So waiting for that spontaneous delivery of the placenta is really recommended unless you're seeing a lot of arterial bleeding from your hysterotomy. And doing a two-layer closure of the uterine incision has been shown in patients who undergo trial of labor after C-section, reduced risk of that uterus rupturing, which may still happen with like a low transverse incision, but by doing this two-layer closure helps to really strengthen that uterine scar and everything. Once you've kind of opened up everything, and then we have to close everything. But they've shown on our pathways that closing that peritoneal layer doesn't need to be closed, because the body naturally reperitonealizes within 12 hours. So routinely, this does not need to be closed, and because of the different innervations, nerves of the peritoneal layer, that this actually can increase postoperative pain. So by leaving it open, helps to decrease that. It's important to close the fascial layer. That is required for all abdominal surgery. And finally, in patients who have a subcutaneous layer of greater than 2 centimeters, to reapproximate that, because in this layer, if there's any areas where a pocket can form, basically dead space, your body recognizes that and starts to fill it up with fluid. That fluid, although sterile, may become infected with bacteria and lead to surgical site infections, things like seromas, which help to decrease the risk of surgery, site infections and wound healing. So by reapproximating that subcutaneous layer in patients where that is deeper than 2 centimeters, has been shown to decrease those risks. Lastly, with closing the skin, using subcuticular closure methods such as subcuticular staples, which use basically kind of a dissolving staple, and sutures, as opposed to just regular metal staples, which are removed in about 4 to 7 days, helps to decrease that risk of surgical site infections routinely. So. Great. We're going to talk about some clinical considerations when we're approaching a patient who's undergoing cesarean section. So some things are such things as distorted anatomy, helping to decrease that risk of patients who are developing postpartum hemorrhage. So some prophylaxis things with medication. The patients who are undergoing repeat cesarean section and have had prior abdominal surgery, so a lot of adhesions and scar tissue that may form. We'll talk a little bit about some suture material, the different surgical approaches, and then finally the wound vacuum and its clinical indications. So great. So sometimes when we're undergoing cesarean section, we may encounter patients who have distorted anatomy, that they're super morbidly obese, BMI is a 40 or greater, and the pannus, which is kind of that abdominal skin, that hangs in like a apron-like fashion, may distort the anatomy of where the pubic bone is, and being able to access that. So there's been some studies that show, making a incision above the umbilicus in these severely morbidly obese women, because of the way the abdominal pannus drapes down caudally, towards the patient's feet, actually is where that 2 centimeters above the pubic bone is, and making that incision higher up. Other things that we may do is kind of avoiding, going through many, inches of subcuticular fat, to try and get to the fascia, which may be encountered with making that kind of incision, but kind of lifting up the lower abdomen stomach with things such as pannus retractors, to really help make our way into that, area of that 2 centimeters above the pubic bone, so that we can make our transverse incision and everything. The biggest factor of making incisions below the pannus is that, we want our skin incision to stay nice and dry. That's the key, to any kind of surgical wound healing, is, keeping it clean, dry, and intact. So, that may be difficult in patients who have this apron of, abdominal skin, over the incision that can harbor, moisture and bacteria. And using different methods, and counseling the patient on surgical wound techniques, washing your wound with soap and water, keeping it dry, using a towel there, really helps to prevent those surgical site infections superficially. Next thing we're going to talk about is postpartum hemorrhage. So as I discussed with, epidemiology of C-section, that there is that risk of postpartum hemorrhage and, bleeding risk. And one of the biggest things that came out in 2018 was the use of TXA, or tranexamic acid, which is a medication actually used in a lot of emergency medicine fields to prevent bleeding and excessive hemorrhage of patients. Is the use of it actually in obstetrics, and using it to prevent blood loss. What TXA is a medication that blocks plasminogen, so which is a part of the clotting cascade that breaks down fibrin. Fibrin is required in order for a clot to mature and form. So by preventing that fibrin degradation, you help to decrease that bleeding risk. So it's given most commonly as 1,000 milligrams IV. It's very cheap. It's about $18, to use. So it's, has really been shown to help decrease the risk of postpartum hemorrhage, which is, the definition is about 1,000 milliliters of blood loss, from the surgery within 24 hours. So it has really been shown to decrease that risk of postpartum hemorrhage in these patients. In patients who've undergone other abdominal surgeries, such things, gynecologic wise, such as myomectomy, removing fibroids from the body of the uterus, other different types of abdominal surgeries, previous C-section as well, can basically have, dense adhesions, or basically scar tissue form between the different layers on the inside in the peritoneum. So really that preferred modality, in order to get through these dissections and everything into that peritoneal space, is using sharp dissection. Sometimes surgeons may use electrocautery, and avoiding that excessive electrocautery in these patients, can help to decrease risks of damage to surrounding tissues and organs. And you see in this picture, even though this is done laparoscopically, you see the uterus, posterior, all these massive adhesions to the underlying sigmoid colon and omentum. And I believe this also had a lot of, adhesions to the bladder as well. So, can make, your surgical approach much more difficult. So really, taking your time to find, tissue planes in order to, just isolate the uterus itself are key components, in order to avoid damage to surrounding tissues and organs. Next, we'll talk a little bit about suture. So, suturing and the hysterotomy and through all the other different layers in a C-section, has really been around since we've had suture. The biggest things in the past was using what are called catgut or bovine derived from connective tissue, and that's braided, that dissolves over time. A lot of the times now we use synthetic suture. So looking at different suturing packets, you have, the different names of them. Vicryl, Ethicon is the big suture company that makes a lot of these different devices. In order to describe if it's natural or a synthetic suture. It'll talk about the gauge. So when you have 3.0, that's actually, even though that's a larger number than such as a 2.0 or a 1.0 or even a 0, those are actually smaller gauges of how large it is, the thread of the suture. So an O vicryl would actually be thicker than a 3.0 vicryl. Talking about the needle size and the curvature, so there's things such as SH or CT, basically is how semi in a hemisphere SH, some of the CT ones are less so. These are all different types of how the needle is curved in order to go through the tissue. The different needle points. So the ERAS protocol talks about different needle points using blunt-tipped needles as opposed to cutting type needles or sharper needles, pointed needles. And that helps to just decrease the risk of damage, to surgical assistance, to the surgeon itself. And also the blunt tipped is able to go through all of the layers as well as a cutting needle. So, but those can be much more expensive as opposed to the different cutting needles. So it all is preferred, by the surgeon, what type of needle point. And it doesn't help to, patients, morbidity with the procedure itself, so that it can be kept up to the surgeon. And then such as different types of suture, the thread may be either a monofilament or a polyfilament. So basically multiple different threads braided together. The difference with a monocryl is that there is a decreased risk of bacteria adhering to those types as opposed to a braided suture where it allows different, more space for bacteria that can be adhered, but it really all depends on the surgeon preference on types of filaments. I myself use monofilament just because of the ease. It's quicker and it goes through the tissue fine, and there's less of a response of inflammation because of the synthetic nature of the monofilaments, how they're broken down. Your body hydrolyzes them, so basically that tissue undergoes hydrolysis just of like the surrounding tissue is how it breaks down, as opposed to some of the other types where macrophages recognize that this is a foreign breakdown and undergo that kind of breakdown, which can have more of an inflammatory response. So lastly, we'll talk about some of the different types of approaches. So the fan and seal, Joel-Cohen, Miscavige, and modified Miscavige are all different types of the same steps, but using it differently. So with the skin incision, making that types of skin incision, and then the subcutaneous layer either sharp or bluntly entering, making an opening through the fascia, either sharp or bluntly entering it. Peritoneal, opening it either sharp or blunt, with the uterine incision, either sharp and then blunt entry. With the placenta, either removing it manually or allowing it to spontaneously detach. With the uterine closure, either using a single layer interrupted or multi-layer as well. With the peritoneal closure, not closing it or closing it. The fascial closure, either doing interrupted or continuous, so running sutures. The subcuticular closure, in patients, where that is less than 2 centimeters, not suturing it, but it is recommended, in greater than 2 centimeters to close it because of that, closing the dead space, as I talked about. And then with the skin, either using continuous sutures, or staples, or either what's called mattress suture, which is basically a way to decrease the tensile forces on the skin to allow the skin to come together nicely. So lastly, I'd like to talk a little bit about what's called a wound vac. So wound vacs have been shown to help reduce the risk of surgical site infections and improve healing times as part of comprehensive clinical protocols. This has really been shown with women who have BMIs of 30 or greater that are undergoing C-section, as well as if they have other kinds of conditions that may preclude and may cause them to be at risk for developing surgical site infections such as diabetes, cardiovascular disease. What a wound vac is it's placed on top of the incision after the skin has been closed together, and it uses negative pressure to basically reapproximate the edges to pull through any of that serous tissue, serous fluid, so that it does not become a nidus or source of infection for bacteria to come to, and really helps to increase oxygenation, which is really keys, as we said, keeping that wound clean, dry, and intact really is, important to wound closure and wound healing. So, this is what's shown here is a Pico dressing, but there are many different types of these negative pressure wound systems. So finally, we're going to go over the evidence-based stepwise approach. So we're going to put it all together in doing a primary low transverse cesarean section. So you'll see in our first diagram, we're making that skin incision after marking it. We'll make that incision about, 10 to 12 centimeters in length. That allows, adequate exposure, allows, the head, which is about 10 centimeters and able to come through all of our incisions. And, that is cut with suture to the subcutaneous layer. As we talked about that, the preferred modality is blunt entry. So using, your fingers with your surgical assistant to really open up the subcutaneous layer to the underlying fascia, which is that white kind of silver skin type layer overlying the abdominal rectus muscle. So making that incision on the fascia to kind of open up the underlying muscle. And as we discussed, that blunt entryway into the, past the fascia into the abdominal rectus as well, and opening up at midline of the abdominal rectus into the underlying peritoneal cavity. Once that peritoneal cavity has been opened up, then bluntly entering it, kind of separating everything with your surgical assistant to allow visualization and entry to the underlying uterus. Once that, we've opened up and seen our uterus, we can make that, superficial incision and then bluntly, open up the uterine, the hysterotomy incision. You'll see, the underlying membranes are exposed, and we see the bladder is, outside of our operative field. Bluntly entering and opening up the uterine hysterotomy. And then we have our delivery of our baby. Good. Excellent. So in conclusion, cesarean section is a commonly performed procedure, and there's many evidence-based surgical practices which are applicable to the procedure. So we know that carb loading these patients prior to the procedure using antibiotics that are weight-based, as well as inclusion of azithromycin in case of rupture of membranes or a patient who's in labor are keys, as well as with skin preparation in preoperative optimization to prevent surgical site infections and faster recovery time. Intraoperatively, we know that based off studies that the Joel Cohen skin incision followed by blunt entry, repair of the uterus in 2 layers, repair of the fascia and the subcutaneous layer if it's deeper than 2 centimeters, as well as subcuticular skin repair has been shown to decrease risks of surgical site infection, decrease risks of bleeding, as well as decrease risks of different postoperative pain medications. With the opioid crisis, using these methods, will help a patient to not use those narcotic medications and use things such as Motrin, Tylenol, anti-inflammatories, other different pain pathways such as gabapentin, which are neuropathic medications, to control their pain. But really intraoperatively, we're able to do these, modalities which can help decrease that as well. So really key and important. Lastly, that the bladder flap and manual extraction of the placenta, although routinely can be performed, are not routinely recommended, unless clinically indicated, because of those risks of bleeding, of increasing operative time and everything. And, with C-sections, there's going to be a lot of ongoing studies that will help to further elicit, management of the operative and post-operative course of patients who will undergo C-section. So with that, I think it's now all of you guys' turn, to perform your C-section. So thank you so much for having me, allowing me to present. I think I'm going to stop sharing my screen now, and we will open up now to questions.
All right, so I think we have time for about 2 questions. So let me pull it up. Our first participant asked, with the recent increase of awareness and conversations concerning Black maternal health and infant crisis in the US, how have OBGYNs tried to combat this issue, and how do you as an individual physician also try to combat the issue as well? What are some causes that you believe contribute to this problem?
Sure. So, that's the big factor, especially as a provider of women's care, is, dealing with at-risk patient population. So, patients of African-American descent have been shown to have higher incidences of, morbidity and mortality, not only to the mom, but also to the baby, throughout labor, compared to non-African-American patients. So, really tailoring it to understand, that making sure that these patients are able to access, prenatal care, because, starting prenatal care early helps identify a lot of these risk factors, such as obesity, chronic medical conditions such as diabetes, hypertension, which can cause the mom to develop conditions such as preeclampsia, which may warrant emergent C-section or even preterm delivery, causing these patients to be at risk for many different things. So those are ways that we're able to combat it, is by making sure that all women are eligible to get prenatal care. That's one thing in the United States, with our medical system, that we require insurance, but all pregnant women are eligible to, receive medical care during pregnancy. Another big factor is not only just in pregnancy, but in postpartum is where we see the biggest risks of cardiovascular disease, which, unfortunately, there's a disproportion of African-American patients, that die of cardiovascular, heart attack, stroke, after pregnancy. So by continuing that postpartum care, and one thing that ACOG is really big with is ensuring and lobbying to a lot of these insurance companies that that once a patient has been delivered, don't stop their insurance, at that time, that they need to have, their continued care up till that 6 to 12 weeks after postpartum, so that they can be well established with, different specialists, cardiologists, their primary care physician. The other factor is that with a lot of OBGYNs, we are, even though a subspecialty, we're really the key point of where a lot of women are able to get their, their care initially, primary care of lipid panels and everything. So really, it relies on us to, tease out a lot of that history from women. So, that's kind of the beauty of women's health, is that we kind of do it all, even though we're a surgical subspecialty, we're also primary care in regards with that as well. And getting a lot of these women, to, have their first access to care, is really key.
All right, and for our last question, is it more common for C-sections or number of births to cause uterine prolapse, or neither? And do either of these skin incisions damage, or sorry, do any of these skin incisions damage nerves?
Sure. So, it's the biggest factor that they've seen with studies is that uterine prolapse, so, the pelvic organ prolapse has been shown with vaginal birth, and it's been shown, that there's decreased risks of pelvic organ prolapse in C-sections. This has only been shown for the first 5 years. And then later on in life, there are basically these populations of women who've undergone C-section and vaginal birth, are basically the same. So, I think I talked on it a little bit that, it may decrease the risk of pelvic organ prolapse and even urinary incontinence with C-section as opposed to vaginal birth. But, long term, the risks of undergoing, C-section, does not allow, for that increase, or decreased rate of pelvic organ prolapse and urinary incontinence. So it should not be recommended as opposed to vaginal birth. And vaginal birth is the preferred modality, as long as the patient doesn't have contraindications to it. So, and with the second question of the skin incisions damaging the nerves. So that's why we make our incision at the midline and really tailor it to just that, 10 to 12 centimeter size, because a lot of the vessels and the nerves are run more lateral to the incision. So by making also that incision about the 2 centimeters above the pubic symphysis, a lot of the nerves are right above the pubic symphysis. So we kind of help to avoid those nerves that underlie and innervate the abdominal wall. So.
All right, perfect. Thank you so much for answering our questions. I know there were more questions you guys had. Please feel free to email him at the provided email. Thank you again, Dr. Sabre, for coming out and giving us this talk. This was a great lecture and I really enjoyed it. I'm sure everyone else did as well. Sure.
Well, I'm happy to, answer any other questions and everything. I know we just have a few minutes and everything, but yeah, I appreciate it. Thank you so much for having me. And yeah, for people who are interested in, pursuing OBGYN, I think I have, my contact information there, and I look forward to either further questions or, networking opportunities with you all. So thank you so much.
Yep. So next I'll have you guys all transition to our next room so that we can do our closing statement for the day. Thank you guys so much for attending. We'll see you next time.